Hello everyone, happy afternoon, a very good afternoon. I hope and I believe all of you are doing well. A quick note everyone, am I audible and visible everyone? Am I audible and visible everyone? Great. So here we are into the image-based discussion. We'll be discussing the important, the must-know images in radiology. It's like for every or any exam that you go, these are the images that you definitely have to know. So we'll also understand, how to interpret the black and white of radiology so that if you get images beyond this in your exam, you should be able to interpret that, right? So we have seen in the recent exams, there are radiology images which might be the bit eccentric ones, but if your black and white concept, the principle is well understood, you'll be able to interpret those images as well. Okay, thank you so much everyone. I'm doing well, right? Fine as well. Thank you so much. So without any further delay, let's start the today's session. Okay, so we'll go systematic wise. Like first we'll look at the important investigations that you are asked to identify, then the anatomy, and then the various systems. So we are focusing only on the most important images and the ones that are frequently asked and have been asked in your exam. So first one here, look at this. Look at this image. Is it a CT or it's a MR, right? Very, very important. So whenever you're identifying CT versus MR, always look at the bone and particularly the bone cortex. CT is like X-ray, right? CT also uses X-rays. So the bone is going to be white in CT. So this is the bone that you are seeing here, which is white. And that is why this is a CT here. Okay, what are you seeing here is a CT. Look at these three images here. Please do not look at the outermost lining where you are seeing the white outline. That's not the bone. That is the fat, the scalp fat, which is appearing white. So this fat is white on MRI. You can see it is white on T1. It is white on T2 as well. It's white on FLAIR as well. So fat is something which is white on both T1 and T2 MRI. Where do you look for bone is just outside the brain outline. If you are seeing a black line, just outside the brain parenchyma, you are seeing this black line. That's the bone there, right? So that is the black bone and that is why that is going to be MRI. Okay, never make this mistake in the exam. It's going to be a blunder, right? Now, how do you identify it's T1, T2 or FLAIR? We have learned the tricks in our videos in the PrepLadder app, right? If the water is white, if the water is white, remember WW2 World War II, it's a T2 weighted MRI. Where do you look for water? The CSF in the ventricles, the CSF in the sulcal spaces. If the water is not white, like you are seeing in these two images, the water is not white. So it is T1 or is it FLAIR? How do you identify? Then look at white matter. T1, 1 is your first year subject, 1 year subject, that is anatomy, is followed in T1. White matter is white and gray matter is gray. As is their anatomical name, so is their appearance. So the white matter, you can see this corpus callosum, the subcortical white matter, the internal capsule. This is white. So white matter is white. It's a T1 weighted MRI. If everything is black, the water is also black, the white matter is also black, it's going to be FLAIR, right? It's going to be FLAIR. So FLAIR is a sequence where the pathology stand out because the water and white matter are black. Any pathology appearing white, that will stand out in FLAIR. Is this clear with everyone? So this is T1, FLAIR and T2 weighted MRI, and remember all of these are MRI images. Okay? Yes. FLAIR is basically fluid attenuated. The fluid becomes dark. The CSF becomes dark. The pathological fluid edema does not become dark. Edema is going to be white on FLAIR. So when we want to look at edema, FLAIR is the first sequence that we look at. Okay, let me ask you one question here. Can somebody tell me, think logically and tell me what are you seeing here on CT? Right, so this is like a quiz question here. Tell me what is this white here that you are seeing in this CT brain? Yes, anyone? So you answer it and you ask for sorry before that. Very good. That is white, right? So white on CT is either calcification or acute hemorrhage. See, think logically. Now, for those who are saying pineal gland single gland hota hai. It's in the midline that you see the pineal gland. It's not a bilateral structure. So this is not pineal gland. This is calcification, but where? Calcification where? So these are the posterior horns of the lateral ventricle where you have these choroid plexus which are present. So this is definitely, you are correct. This is calcification. Choroid plexus calcification. The lateral ventricle, which is the paired ventricle, uska calcification has happened. It's a physiological calcification that happens. Okay. So that is choroid plexus calcification. Absolutely right. Okay. Going to the next one, identify this MRI sequence has been asked previously. So when you have an MRI sequence which looks very different from T1, T2 flared, you see those black areas of blooming. What are these black areas called as? Areas of blooming. What do they indicate? They indicate hemorrhage or they can indicate calcification. SWI helps you to differentiate that as well. So hemorrhage or calcification. For hemorrhage, what is the sequence? This is SWI. Susceptibility weighted imaging. Okay, this is susceptibility weighted imaging for hemorrhage. Right? What is the MRI sequence which is the most sensitive for acute infarct? For acute infarct, the most sensitive sequence for acute infarct is, very good, it is DWI MRI. Diffusion weighted imaging is what you do for acute infarct. DWI MRI picks up very early infarct as well. Diffusion weighted imaging, acute infarct shows restricted diffusion. Okay, acute infarct shows restricted diffusion. SWI is a very good sequence to pick up hemorrhages, tiny hemorrhages, like in a patient of diffuse axonal injury. Okay, diffuse axonal injury. Next one, look at the image A and look at the image B. CT, MR, MR, CT, both MR. What is it? We'll talk about infarct later when we come to emergency radiology. We'll discuss it there. Okay, green. Kaya, don't worry, this covers majority of your PYQs and PYTs, except for few that have, those have also been discussed in your APCA videos. CT, MR, MR, CT, what is it? Both CT, both MR. Great, right? Another commonly made mistake here, please do not look at the bone ka inner side, right? The inside of the bone. Please look at the outer surface of the bone cortex. If the bone cortex is white, it is CT. This is the bone cortex here, which is black, it is MRI. So A is CT and B is MRI. Do not look at the bone marrow. Why is the bone marrow dark here and why is the bone marrow white here? Because the marrow here is the fatty marrow. Fat is dark on CT and fat is white on MRI. Okay, until and unless it's a fat suppressed sequence that you are doing in MRI. Otherwise, the fat is white on MRI. Okay, so look at the bone cortex. This is the CT of the knee and this is the MRI of the knee. Tell me that what is this structure here? What is this black structure that you are seeing here? This is also a PYQ, has been asked previously. What is that? Very good. That is the posterior cruciate ligament. Okay, going to the posterior end of the tibia. Where will you see the ACL will come like this and the PCL goes behind. Okay, ACL and PCL. Look at the image A and look at the image B. What investigations are these? Both CT, both MR, ACT, BMR, AMR, BCT. What is it? Correct. Cruciate matlab crossing. Both are CT. What is the difference in between the two then? Why are both CT? Because the bone is white. Because the bone is white. So both of them are CT. The difference is, look at this round structure aorta. Look at this round structure aorta is gray here. Aorta is white here. When you see the aorta is white, it is telling you it is a contrast enhanced CT and this is a non-contrast CT. So A is non-contrast CT. B is contrast enhanced CT. Right? So in the contrast enhanced CT, you will see the vessels appearing white. What contrast do you give in CT? It is iodinated contrast. Okay, what contrast do you give in CT? Is iodinated contrast is given IV. IV iodinated contrast. Okay. So the importance of doing the contrast CT is it helps you pick up lesions like this, which can otherwise be missed on non-contrast CT. Non-contrast CT is investigation of choice for, see, non-contrast CT is going to be investigation of choice for things which are already white on non-contrast CT. So you do not need to add contrast to make them look white. So one is calcification, which is already white. Second is acute hemorrhage, which is already white. Example of calcification, renal stones, ureteric stone, right? So they are calcified stones. So you will do CT for renal stones. For gallbladder stones, you would do USG. Okay. Coming to the concept of HU scale, where do we use HU scale in CT? Right, the Hounsfield units. Every substance has a HU value depending on its density, particularly the electron density. The more dense the substance is, the more is the HU value. What is the reference substance, the standard substance taken in the HU scale? The reference, that means which has HU value of 0. This is one of your recent NEET PG INICT exam question. It is water. Okay, the standard, the reference is water. Right, so water is given a HU value of 0. Whatever is less dense than water, it has a negative HU value. So remember, air and fat, very, very important. What substances have negative HU value? It is air and fat. Fat is oil, which is less dense than water. So remember that it is going to be negative HU value. Air is minus 1000, fat is minus 52, minus 100. So that means both of them are going to appear dark, appear black on CT. Out of that, which will be jet black? Absolutely black. Air is going to be jet black. Fat is said to be dirty black, like black but not jet black. Water is said to be gray. Water fluid appears gray. Whatever is more dense than water, like the bones, the contrast, they will appear more bright as compared to water. Okay, yes, if you want it to be specifically correct, it is distilled water, which is 0. Okay, distilled water. Okay, so now look at this image and tell me, what are you seeing here? So this is a CT of the pelvis. You can see some mass. What does the mass contain? What is this white that you see in the mass here? And what are these black areas that you are seeing in the mass? So it is containing calcification, right? There is calcification and there is presence of fat. So pelvic mass in a female with fat and calcification. What ovarian mass it is going to be? It is going to be a dermoid teratoma. Very, very important. Okay, so fat and calcification containing is going to be teratoma. Your last NEET PG exam question, you can have a mediastinal teratoma as well, which will have fat and calcification. Fat will have negative HU value. Okay, very, very important. Going to next one, identify this investigation. So look at this image and look at this image. Both of them look similar. You know, there is this some endoscope which is coming. You can see a duct here, which is the common bile duct here, the biliary tract. So both of these are ERCP. Okay, both of them are ERCP. So I want you to understand that ERCP. What is ERCP? ERCP, does it have radiation exposure? Yes or no? Does it have radiation exposure? ERCP. Yes, it's a contrast X-ray. It is done under fluoroscopy. It's a contrast X-ray which is done. It has radiation, right? Remember, ERCP has radiation. You put the endoscope, you put the contrast, right? Catheter and contrast, and then you take the X-ray images. So fluoroscopy is an investigation where you get the video of the X-ray, and it can have the images look black or it can have the images looking white, right? So it can be black also or it can be white also, right? So remember that all your contrast X-ray studies done under fluoroscopy, like even HSG, IVP, they can have the black appearing contrast and they can have the white appearing contrast as well, right? On the other hand, look at this image. You can see the CBD, you can see the pancreatic duct. This is the gallbladder. You are not seeing any endoscope. This is what is MRCP. MRCP is MRI. It has no radiation. Ultrasound and MRI do not have radiation. X-ray and CT have radiation, right? So this is MRCP. This is ERCP. And advantage of ERCP is that it is therapeutic as well. MRCP is not therapeutic. It's just a imaging. You cannot remove the stone in MRCP, but you can remove the stone in ERCP. Okay. Going to next one. What investigation is this? Yes, one important question here in MRCP that you should remember is, in MRCP, what sequence of MRI will you use, T1 or T2 weighted MRI? Logical. You want to see the bile, the fluid, which is, you want it to appear white. Water is white on T2. So it's a T2 weighted MRI. It can make the bile appear white even without contrast. It's not necessary to use contrast in MRCP. Okay, clear with everyone? Okay. Okay, very good. What is this investigation here? This is PET CT, right? So you are seeing the white bones. This is CT, and you are seeing the orange color. So when you see a orange colored CT, it's a PET CT, which is done for cancer staging, right? And PET CT has radiation. PET also has radiation. CT also has radiation. Out of that, PET is the functional imaging. All your nuclear medicine scans, they come under functional imaging. PET is done in a nuclear medicine department. It is functional. Look at the image A, look at the image B. Are both of them Doppler? What are the images here? Are both of them Doppler images? What are these? Right. So if you look at the first image here, this is showing the velocity, right? Centimeters per second, showing the velocity of the blood flow. So this is what is going to be Doppler. Doppler is for blood flow. Okay, this is a spectral Doppler. Duplex बोलते हैं, spectral Doppler बोलते हैं, right? And this one here, colorful image ultrasound is there, but this is not a vessel that you are seeing. This is the trachea. यहाँ पे जो air black दिख रहा है, यहाँ पे पीछे नहीं दिख रहा है, shadow आ रहा है. This is air का shadow. And in front of that, this is the thyroid, right? The isthmus and then the lobes of the thyroid. And look at the unit which is mentioned here. It's not centimeters per second. It is kilopascals, which is the unit of strain. And this tells you that this is elastography. Okay, this is elastography. This is not a Doppler. Elastography tells you that how stiff is the lesion or the organ. ठीक है, so जब liver में fibrosis देखना है, fibroscan, it's a type of elastography. ठीक है, correct. Tell me, what investigation is this? What is this investigation? Is it a X-ray? Is it a CT? Or is it a MRI? Very good. This is a X-ray image where you are seeing the contrast in the bowel loops. What is that contrast? That is the barium. What bowel loops are you seeing here? You are seeing the stomach and all the small bowel loops. So this is BMFT, barium meal follow through, which is done for small intestine. Remember, barium is contraindicated in what condition? Very, very important. Barium is contraindicated in perforation. So what do you give in perforation? Give iodinated contrast, which is water soluble. Barium is water insoluble. Okay, give iodinated contrast. Going to some important anatomy images. Okay, let me ask you this. What do you think is this structure here? What do you think is this structure here? Yes. Very good. The court surgeon, absolutely right. That is stomach. So you guys are smart. Now, how do you identify the stomach and not the spleen? First of all, understand that in your radiology images, your left is the patient's right and your right is the patient's left. So this is on the left side that you are seeing here. So stomach or spleen, remember it is containing the air foci. Black is the air, gray is the fluid. So air containing is going to be stomach. Behind the stomach, the solid organ that you are seeing here, this is going to be spleen. This is the stomach here, and on the right side, this is the liver, right? This one that you are seeing here is the liver. To the left is the stomach, and then is the spleen. And this one here is the aorta. Okay, this one here is the aorta. Look at this one here. Again, this is the liver that you are seeing. To the left of its stomach, this is another bowel loop that you are seeing. This is the spleen, and this bilateral structures that you are seeing here. This is the right kidney. This is the left kidney. Do not get confused between right and left. Your right is patient's left. This is aorta here, and to the right of the aorta, what is this structure here? To the right of the aorta, it's going to be its vein. What is that vein? The inferior vena cava. And what is this in front of the IVC? Inferior vena cava going to the liver. This is going to be portal vein. Okay, this is going to be portal vein. Superior vena cava thorax में आएगा, abdomen में inferior vena cava आएगा. And what are you seeing here? What is this structure here? Going towards the spleen, this is going to be pancreas. Okay, this is going to be pancreas. So recent FMGE exam, stomach, liver, spleen, pancreas, right? They have been asked in anatomy, very, very important. Another important anatomical section that is asked in the exam, the mediastinal vessels. This is CD chest, black is the air lung. Look at 1, 2, 3, 4. What are the structures labeled 1, 2, 3, 4? Again, this is right side, this is left side. From right to left comes the SAP. Okay, remember this as SAP, the 3 vessels here. First is superior vena cava, then ascending aorta, and then pulmonary artery. Okay, and what is the structure labeled 4, which is in front of the vertebra? Posterior mediastinum is going to be descending aorta. Okay, that's a descending aorta. What is 5 and what is 6 here? 5 and 6 you can see are containing air. They are black color, right? And that is the trachea, which is already divided into the bronchus. So 5 and 6 are the bronchus. Okay, 5 and 6 are the right and the left bronchus, air containing. Is this clear with everyone? Very, very important, right? This is right bronchus, this is left bronchus. Pulmonary artery, inverted Y shape, dividing into right and left into the lung. Okay, this is very, very important. Recent, this was asked in the recent NEET PG exam. All right, look at this image here and tell me what is this structure. What is this structure here? Yes. Is it right rib, left rib, clavicle, scapula? See, first of all, understand that you are at the level of the chest. These are the black lungs, right? So you are at the level of the chest. So it's not going to be iliac crest, right? Next, what you see is these are the ribs which are forming the thoracic cage like this. These bones are the ribs. Behind the ribs, you are seeing this bone. So what comes behind the rib cage? That is the scapula. Okay, you are at the level of the lung. The clavicle comes here at the lung apex. Okay, so that is not the clavicle. This is the scapula. Okay, so this is the scapula. Is this clear? Right? And what is this structure here? What is this structure here? Important. It is forming like an inverted C arch around the trachea. This black is the trachea. Behind that, carefully, if you see a small air speck containing structure, that is the esophagus. This is the arch of the aorta. So what is this structure here to the arch of the aorta, right of the arch of aorta? This is superior vena cava, right? So that is how you identify SVC. And this is not the pulmonary trunk. We are at the level of the arch. Okay, we are at the level of the arch. This was asked in your last year NEET exam. So this is again trachea. This is the arch of aorta. You are seeing one branch which is coming from the arch of aorta going in front of the vertebra. So this is an aberrant branch. What aberrant branch is this? This is ARSA, aberrant right subclavian artery, which is the last branch coming from the arch of aorta, and it goes from the left side to the right side in front of the vertebra. Okay, and this is again your another image, trachea, and you can see 4 vessels here. The 4th vessel that you see in front of the vertebra, that is going to be ARSA, aberrant right subclavian artery, which compresses the esophagus, causing dysphagia lusoria. Okay, ARSA, aberrant right subclavian artery. Clear with everyone? Going to next one, identifying the chambers of the heart. What is the chamber? 1, 2, 3, 4. What is this first chamber here? Understand that the anterior most chamber of the heart, you are coming from the front, behind the sternum. सबसे पहले anterior most आता है right ventricle. Posterior most आता है coming from behind. What is the posterior most chamber? That is 3. That is going to be left atrium. Right ventricle का उल्टा left atrium. Now this is the midline of the heart. This is the left side of the heart that you are seeing. Left side, your left. So it's going to be the patient's right side. So if this is the right ventricle, this is going to be right atrium. If this is the left ventricle, left atrium, so number 4 is going to be left ventricle. Okay, so this is how you identify the heart chambers. Has been asked twice in your previous exams. Identifying the heart chambers on CT. Very, very important. Is this clear with everyone? Okay, and what are these structures? Logically thinking, what are these structures? Where are they draining? Into the left atrium. If they are draining into the left atrium, so what are they? They are pulmonary veins. This is how you logically think in the exam when you are given image like this. You will say that ma'am ने तो सिर्फ heart chambers discuss किया, but exam में तो ये पूछ लिया. Think logically. In what chamber is it connecting? Left atrium, so it's going to be pulmonary vein. Okay, that's going to be pulmonary vein. Going to next very important and a confusing area, counting the ribs. This is your recent favorite with the examiners for radiology. How do you start counting the ribs is, start counting from the anterior first rib. Now remember that the posterior rib is something which is horizontal and the anterior rib is oblique. So ये जो oblique दिख रही है, these are anterior. और ये जो horizontal दिख रही है, these are posterior. So start counting from the first anterior rib. The first rib is a broad rib. So you start counting from the first anterior rib, trace it backward. Second rib, you trace it backward. So you can see the first and the second rib are very close together posteriorly. This is where generally the mistake is made when you are counting the ribs. Okay, so understand that first and second are very close together. Then you have the third rib, the fourth rib, the fifth and the sixth, then the counting becomes easy. If you are counting the anterior, this is first, second, third, fourth, fifth, right? This is how you'll count the anterior. Posterior may please remember you start counting from anterior end. So for example, if I ask you that, what is this rib here? Right, left, anterior, posterior, 4, 5, 6, third, what rib is this? Which rib is this? Right, left, anterior, posterior, and what number? Yes? See, first of all, it is right or left. This is on the left side, right? R is written here. This is right, this is left. Anterior or posterior? The rib that you can see very well on a chest x-ray is the posterior end. It is seen better, right? And it's more horizontal. The anterior are going to be these ends. These are the anterior ribs. The ones that you are seeing very clear, more better, these are the posterior ends. These are the anterior ends. Okay, so this is not anterior, this is posterior. Left posterior. Now coming to the counting. As I said, start counting from the first rib, anterior end, which is broad. This is the first rib. This is the second rib. So first and second are here. So third, fourth, fifth, sixth. This is how it goes. So this is going to be fifth, fourth, third, second, first are very close together. This is 6, 7, 8, 9, 10. So this rib that you are seeing here is the left posterior rib. So congratulations everybody who got it right. This is left fifth posterior. Okay, this is left fifth posterior. Is this clear with everyone? Right. So this is going to be the, if you see very carefully on the right side, there is one rib which is coming like this, more vertical. Right, first rib ke bhi upar, that is the cervical rib that you are seeing here. Okay, so this one that you are seeing here, that is the cervical rib that you are seeing here on the right side. That's the right cervical rib. Okay, clear with everyone? Vapas dekhna hai, so let us let us count. If you want to see the rib counting again, look at the first rib anterior end, the first rib that you see anteriorly, which is more broader as compared to the rest of the ribs. So this is the first rib anterior, trace it backward. This is the first posterior. This is after that, the next one, this is the second rib, trace it backward, this is second. This is the third, right? So you know that this is third posterior, below that fourth, below that five, this is six, this is seven. You have to pay special attention to the first ribs that you are counting here, because like I said, this is where generally the mistake is made. The first or second को हम एक ही count कर लेते हैं, इसलिए वहाँ पे गलती होती है. ठीक है? So that is what you have to be very careful about. This is the first anterior and then the first posterior. This is going to be the second one there, right? Third, fourth, fifth. This is how the counting is going to be. Look at more images, right? Whenever you have confusion in any image, the best thing to do is Google Images में जाओ और उसके multiple images देख लो. So that gives you a very good visual memory. Okay, so that is what you should be doing. Okay? Yes. Going to next one, coming to MRI brain. Look at the structures here. What is 1, 2, 3? This is the brain stem. What are you seeing in the brain stem here? This is midbrain, pons, and medulla. Okay. Now look at this one. This is the cerebellum here. This has also been asked in your exam. And what is this structure labeled 5 triangle which you are seeing here? The structure labeled 5 is the fourth ventricle, that triangular area between the pons and the cerebellum. What is the structure labeled 6 in front of midbrain? That is the mammillary body. MB in front of MB, mammillary body in front. Number 7 here, this is going to be the pituitary gland. Right, in the sella turcica, pituitary gland, and surrounding that is what sinus? Number 8. Number 8 is going to be sphenoid sinus. Okay, that is the sphenoid sinus. Then what you have is number 9, corpus callosum. Number 10, this white matter tract here, fornix, part of the Papez circuit. 11 here is thalamus. 12 is the lateral ventricle, right? That is the area of the lateral ventricle. Is this clear with everyone? Where will you have the pineal gland? Pineal gland is below this corpus callosum splenium, behind the third ventricle, below the corpus callosum splenium, and dorsal aspect of midbrain. So this is where you will have the location of the pineal gland, right? Remember, pineal gland tumor compressing the midbrain, causing Parinod syndrome. So pineal gland comes here. Okay, that is where the pineal gland is going to be, dorsal to midbrain. And what is this one here? Previous FMG exam question, which has this heart shape or Mickey Mouse shape, classical. Remember, this is midbrain. M-I-M-I, Mickey Mouse shape, heart shape is going to be midbrain. Okay, that is the midbrain there. Clear with everyone? 7. What is the structure label 7 you want me to repeat here? This 7 one here, this is the pituitary gland. Right, this is the anterior pituitary. Look at the posterior pituitary giving the T1 bright spot, normal T1 bright spot. This is the stalk of the pituitary. This is the optic chiasma that you are seeing. And so the pituitary lesion compress the optic chiasma, bitemporal hemianopia, right? All of this is your integration. So that was about the important anatomy images. A quick thumbs up, guys, if this is clear with everyone so far. Okay, I'll quickly repeat this once. This is the brain stem, right? Midbrain, pons, medulla. This is the cerebellum having those folia. This is the fourth ventricle that you are seeing here. This is the lateral ventricle. Here will come the third ventricle going via the aqueduct into the fourth ventricle. Okay. Then this is the mammillary body. This is pituitary. This is sphenoid sinus. This is corpus callosum, fornix, thalamus, lateral ventricle. Okay, so and this is where the pineal gland is going to be, posterior to the third ventricle. Right? Great. Now, this MRI, you tell me, is it a T2 weighted MRI or a T1 weighted MRI? Think logically and tell me, is it T2 or is it T1 weighted MRI? Very good. You can see the corpus callosum, the white matter is white. So it's a T1 weighted MRI. Okay, it's a T1 weighted MRI. The ventricle is not white. The sulcal spaces, CSF are not white. Correct, it's a T1 weighted MRI. Emergency radiology, what is the image A showing and what is the image B showing? Quickly. What is the image A and what is the image B showing? Both of them are CT. In the first one, what you are seeing is a dark area hypodensity, and this is a hyperdensity. Always remember in radiology, dark is hypo and bright is hyper, white is hyper. So first one, the hypodense is the infarct and the hyperdense is the hemorrhage. White is the acute hemorrhage. Acute hemorrhage is white, chronic hemorrhage is dark on CT. So this well-defined hypodensity here involving the cortex, the gray matter, that is an infarct. So some of you had asked you, why is infarct hypodense on CT? Because what happens in infarct, the tissue, the cell is dying and there comes the edema. So your solid brain parenchyma is being replaced by a lot of water. So parenchyma se water aa raha hai, the density is decreasing. Decreasing density means hypodense. Okay, so that is why infarct is going to be hypodense. Hemorrhage has a lot of RBCs which increase the density, so it is hyperdense. Okay, so what do you do in a patient of infarct or acute hemorrhage? Basically, both of these come under stroke. Focal neurological deficit. Patient cannot walk, patient cannot speak. What is the first investigation that you do in that case? What is the first investigation that you do in that case? Always, any patient of stroke, it's going to be non-contrast CT, because you want to rule out hemorrhage, and because entire management, thrombolysis karna hai, nahi karna hai, that depends on the presence or absence of hemorrhage. So in the CT stroke protocol, you have NCCT, you have CT angiography, and you have CT perfusion, which is done. Okay, remember in the CT stroke protocol, we have NCCT, CT angiography, and CT perfusion. What is most sensitive for acute infarct is DWI MRI. The early infarct cannot be seen on CT. CT can be normal in acute early infarct, but DWI MRI will pick that up. Okay? Right. This is your INI CT question as well. You do CT angiography after NCCT to look for what vessel is occluded. Okay? Going to next one, image ABC. All of these are hemorrhages. White hemorrhage, white hemorrhage. This is the white hemorrhage. What kind of hemorrhages are these? If it is biconvex, not crossing the sutures, it is EDH. If it is sickle shape, concave shape, crescent shape, that is SDH. S for S, sickle shape. If it is in the sulcal spaces, in the cisterns where CSF should be there, that is subarachnoid space. So this is subarachnoid hemorrhage. Okay, that's going to be subarachnoid hemorrhage occupying the CSF wala space. Is this clear with everyone? Okay? Subarachnoid hemorrhage classically presents with thunderclap headache, worst headache of life. Okay? Very, very important. So EDH, SDH, you can see crosses the sutures. It follows the entire brain surface crossing the sutures. EDH does not cross the sutures. SDH crosses the sutures. Okay? Next one, in a patient of trauma, if you are seeing those tiny petechial hemorrhages like this, patient is very bad, the GCS is worsening, and CT scan is showing only these tiny hemorrhages. Classically, this is DAI. Diffuse axonal injury. RTA patient, worsening GCS. CT scan can be normal as well. What is the investigation of choice? It is SWI MRI, which will show these tiny hemorrhages. Right, you have the Adams grading. It can involve the gray matter, white matter junction, the corpus callosum, the brainstem. Depending on what is involved, you get the grading. Right, so classical diffuse axonal injury. Going to next one. This has been asked in your last year exam. You can see this mountain Jessa sign, the mountain Jessa sign. This is called as Mount Fuji sign. Logically, even if you have not seen this image, but can you identify what is it? It is this jet black appearance. What is jet black on CT? Jet black on CT is air. Air in the cephalic cavity. This is going to be pneumocephalus. So the question in INI CT exam last year was, Mount Fuji sign is seen in pneumocephalus, pneumoperitoneum, pneumothorax, pneumomediastinum. Remember, it is pneumocephalus, right? The mountain shape in the cavity in the brain, that is pneumocephalus. This is fast that is being done. Focused assessment with sonography in trauma. Dr. Devaki, good if you are getting that, right? Because this is something that we discuss time and again. This is very, very important. Fast positive hai, fast negative hai. Based on the image, what will you say? It is fast positive or negative? You can see that there is this black fluid. Remember, black is fluid on ultrasound. On ultrasound, what is black is fluid. If you are seeing the fluid is present, it is fast positive. Okay, fast positive. Okay, so this is fast positive. Fluid is present. This is fast or E-fast. You can see the thoracic region also included. So this is E-fast, which helps you to look for pneumothorax, hemothorax, right? So this is E-fast. Do we look for cardiac tamponade in fast? Yes. The first area, the xiphisternal area, it helps you to look at cardiac tamponade. Okay, you look for cardiac tamponade also. So look at the image A and look at the image B, which is normal out of this. Ultrasound, M mode of ultrasound for pneumothorax that we do. Which of these is the normal one? Very good. A is normal. This is the seashore sign. Now, whenever you have to identify the seashore or barcode, look at the lower half of the image and compare it with the upper half of the image. It is looking different from the upper half. This is the seashore, giving more granular appearance. It is same like the upper half. It's just flat lines. It is barcode. Okay, it is barcode. So both of these are same. This is barcode. This is different from the upper half. This is seashore. So you have the seashore sign and barcode sign. Normal people go to seashore. Pneumothorax patients are barred from going to seashore. So pneumothorax is going to be barcode sign, right? Is this clear with everyone? So barcode is what you see in pneumothorax. Next, very important, very important. What are you seeing here? This white line that you are seeing here. What is this white line? The white line is the diaphragm. And what are you seeing here is the black air beneath the diaphragm, air under diaphragm. So this is pneumoperitoneum. Pneumoperitoneum. They give you the history of peptic ulcer ka patient, right? And pneumoperitoneum. And what is this one here that you are seeing? What is this sign in pneumoperitoneum? This big ball of air. This is football sign. Okay, this is football sign. What is this sign in pneumoperitoneum? The ligament connecting the liver and the abdominal wall. This is the falciform ligament sign. Okay, this is the falciform ligament sign, inverted V sign, Wriggler sign, cupola sign. There are multiple signs that you see. Okay, multiple signs that you see in pneumoperitoneum. Next one, coin in esophagus, coin versus trachea. Image A, and then you have patient A and patient B. Which one is the coin in the esophagus, A or B? Which one is the coin in the esophagus? Is it A or is it B? Very good. Now, what you should focus on, look at the AP view, look at the AP view. If in the AP view, this is circle, so remember circle is esophagus. If in the AP view, it is slit like is T, it is trachea, right? So that's an easy trick to remember. If it is circle in AP, it is circle wala esophagus. If it is slit in AP, it is trachea. What is circle in AP is slit on lateral. What is slit on AP is circle on lateral, right? So the example, if you are looking from the front, it is looking circle. But if you look from the side, you will only see the slit, right? So what is circle on AP is going to be slit on lateral. What is slit on AP is going to be circle on lateral. That's how you identify esophagus and trachea. Okay. Now, how do you know that this is coin or button battery? I'm coming to that. Now, look at this one. This is asked again, recent favorite for your exam. If you look at this image very carefully, you can see double ring sign or a halo sign. There is an inner circle and an outer circle, right? And if you look at the lateral view, it has this, ek chota line hai, ek bada line hai. Okay? It is not a flat surface. It has a sloping surface. So, double ring sign, halo sign, or the step off that you see in the lateral, it is suggestive of button battery. And remember, when it is button battery, it needs immediate removal. You cannot keep the button battery inside, even if asymptomatic. It has alkaline fluid, corrosive, right? So you need to remove it, right? So button battery always needs to be removed. Coin, if asymptomatic, in the esophagus, you can wait and watch. Coin in the airway, anything in the airway, you cannot wait and watch. You have to remove it, right? So that is what is the concept there. Okay? नहीं, किसी ने इसको ओरियो साइन नहीं बोला है अभी तक. So that was about the very, very important images, right? One of those is definitely there in your exam, whether it's pneumothorax, pneumoperitoneum, or the foreign body, right? That is definitely there in your exam. Coming to thoracic radiology, recent exam question, what sign and what is the condition here? Yes. Is this air fluid level that you are seeing? Will you call it a lung abscess? Please understand that when you talk about air fluid level is always horizontal. Okay, air fluid level is going to be horizontal, flat. The level that you are seeing here, you are seeing the air and this can be the fluid, but is it a horizontal level? No, it's not a horizontal level here. This is the air in the shape of the crescent. So what is this sign? Air crescent sign. This is not air fluid level. This is air crescent sign, which is seen with fungal ball, right? TB का patient है, cavity है, उसमें fungal ball आ गया. The remaining air is a crescent. So air crescent sign, fungal ball, aspergilloma, right? This is also called as monod sign. Moon के जैसा crescent है. ठीक है, so monod sign, air crescent sign is what you see here. Crescent जैसा air दिखेगा, it is monod sign. Air fluid level will be horizontal. Understand that. Okay? Right? See, whenever you have questions in radiology in exam, there's going to be the background history. Right, Dr. D. Bekey? If it's a lung abscess, it's going to be a patient who looks sick and there is high-grade fever which is there, right? Some aspiration history which is there. If it's a hydatid cyst ka patient, there's going to be contact with sheep, dog, right? Farmer, aisa kuch history is going to be there. So history is also important. And generally in the exam, they will not give you images which are like not like the spotter images. Yes. What is the sign that you are seeing in this image? The lung has become white and through that lung, you can see the black bronchi. So what are those? What is this sign called as? This is air bronchogram, right? Air bronchogram is seen when the lung becomes white. So like in consolidation, edema, hemorrhage, wherever the air is replaced by something more dense. Where will it not be seen? This is important. It is seen only when the lung parenchyma is becoming white, not something white outside the lung parenchyma. So it is not seen in pleural effusion. It is not seen in mediastinal mass. Please remember this point always. It will not be seen in pleural effusion or mediastinal mass. Very, very important. You can see it in severe interstitial lung disease as well, where the lung is becoming almost white, not in the early one. What is this one in this image? You can see bilateral lung opacities, which are fairly symmetrical, and you can see the air bronchogram there. It is more so affecting the perihilar, the central region of the lung. So this is the bat wing appearance that you are seeing, right? This is the bat wing appearance of pulmonary edema. Okay, remember you can see the AB sign, the air bronchogram sign is present. You can see the black bronchi through that. So this is not sarcoidosis. Remember, sarcoidosis has hilar lymph node, which are outside the lung. You can see the air bronchogram telling you that this lung has become white. This is a lung parenchyma pathology. So pulmonary edema. Okay, pulmonary edema. It could be cardiogenic, non-cardiogenic, right? Going to next one image out of this, again very, very important, which is pleural effusion, which is pneumothorax, which is hydropneumothorax. Image A, image B, and image C. Which is hydropneumothorax? ARDS is non-cardiogenic. So there's no cardiomegaly in ARDS and less of vascular congestion. Okay, the cardiogenic pulmonary edema will have cardiomegaly and more vascular congestion. Right. When you see a horizontal level, right, this is the horizontal air fluid level. So air and fluid both. So this is what is going to be hydropneumothorax. Okay, H for H, horizontal level in hydropneumothorax. A curved level, the blunting of the costophrenic angle, curved angle, LSS curve. This is going to be pleural effusion. It has a curve present. And this one here, where do you see pneumothorax in this image anywhere? Right side, left side, where is the pneumothorax in this image? So the left side, this white that you are seeing is the collapsed lung, and this entire thing is the black pneumothorax. You are not seeing any vascular markings, right? The white is the collapsed lung. So this is the left pneumothorax. Okay, this is the left-sided pneumothorax. Pneumothorax will not show any vascular markings. Normal lung has the blood vessels going through it. Okay. Yes, very good. You can see that the trachea is also getting shifted to the opposite side when it's a severe pneumothorax. Okay. Going to next one, based on the silhouette sign, how do you decide what lobe of the lung is affected? If the right heart border is obscured, if the left heart border is obscured. Opacity obscuring the right heart border, opacity obscuring the left heart border. Right heart border is right middle lobe. Left heart border, you do not have left middle lobe. Corresponding to that is lingula. Okay, at least remember this. So it is right middle lobe and lingula. How to distinguish spontaneous pneumothorax? Spontaneous pneumothorax is not like a radiological diagnosis. Pneumothorax is pneumothorax. Now, what is the cause is then what you have to evaluate clinically, and then you will decide whether it's spontaneous or non-spontaneous. Okay? Going to next one. Spontaneous pneumothorax is common in what condition? Marfan's, right? Marfan's patient, tall patients, they have spontaneous pneumothorax common. Yes. So tall male indicating Marfan's. Marfan's का history common दिया जाता है spontaneous में. This has been asked in the FMGE exam. What is this? Left sisal sign, left upper lobe collapse, right? If this is the aortic knuckle, surrounding that you would see the sickle of air. Okay, so and entire rest of the lung will appear white. You will just see some sickle of air here in surrounding the aortic knuckle, the left sisal sign. Very good. This is the wedge-shaped opacity that you are seeing overlying the heart in a lateral X-ray. This is classical image of right middle lobe collapse that you see on the lateral chest X-ray. It appears like this wedge-shaped opacity overlying the heart with the middle lobe collapse, the two fissures of the right lung. Basically, they are coming towards each other. Okay, they are coming towards each other. So classically, this is going to be right middle lobe collapse, right middle lobe collapse. And this is what is here. These are the rounded opacities, bilateral hilar lymph nodes. Bilateral hilar lymph nodes, very, very important, never to be forgotten. It is sarcoidosis. Whenever you have bilateral hilar lymph nodes, always think of sarcoidosis. It can have these paratracheal lymph nodes as well, right paratracheal, left paratracheal. So 1, 2, 3 sign, and if it is left paratracheal, then 1, 2, 3, 4 sign, right? So sarcoidosis classically has this bilateral hilar lymph nodes. Going to the heart appearance, this is the boot-shaped heart. Where do you see the boot-shaped heart? Boot, T-O-T-O, tetralogy of Fallot. Why do you see boot-shaped heart? Because of RBH. This is the figure of 8 heart, snowman heart. Snow falls from supra, from above. So snowman heart, figure of 8 heart, it is supracardiac TAPVC. Okay, supracardiac TAPVC. This is the egg on string or egg on side, which is seen in TGA, transposition of great artery, common when the mother has diabetes mellitus. And this is a heart where the right atrium is enlarged. It grows so big that then it can finally occupy the entire hemithorax, box-shaped heart. Epstein's anomaly, right? There is this right atrial enlargement. Epstein's anomaly, the right atrium gets significantly enlarged. Lithium teratogenic effect is Epstein's anomaly, right? These are must know images. Okay, now tell me, what are you seeing here? All the TTT wale conditions will have cyanosis, right? In TGA, the cyanosis comes on like day 1 itself. Newborn mein dikhega. right? Schmitter sign in PAPVC is where you see the Schmitter sign. Tell me, what are you seeing here in this condition? What is this image showing? Very good. Is it a mediastinal mass? No. You guys are right. There is calcification. Where is the calcification? Great. At least you can pick up कुछ तो calcification है. कहाँ पे है calcification? अब वो देखो. Where is the calcification? Right. See, this one that you are seeing here in the center, it is not some mass. This is the heart. Okay, this is the heart, the chambers of the heart, the aorta coming from the left ventricle. So this is the heart. So this calcification is surrounding the heart, right? So pericardial calcification, this is pericardial calcification, which is seen in calcific constrictive pericarditis, right? So the pericardial calcification tells you this is constrictive pericarditis. Is this clear with everyone? No, this is like a spotter image. Of course, they'll give you the history, like there is pericardial knock, Kussmaul's positive, right? So all this history will be given, but calcification is like a spotter that you should definitely know. Okay? Yeah. Going to next one. Tell me, what is the diagnosis here? What do you think is the diagnosis here? Okay, great. So, Rumisha, you've got it right. Many of you are saying this is a lung abscess. See, what you are seeing here, I'm glad at least you said that lung abscess, because you picked up that there is this air fluid level. But this air fluid level is not in the lung. This is in the mediastinum. This is vertebra, this is aorta, this is heart, और यहाँ पे आता है actually esophagus. इतना बड़ा हो गया क्योंकि ये stomach ऊपर आ गया है. Actually, this is hiatus hernia. Lung abscess you will see in the lung. This is in the mediastinum, right? So behind the heart, this is the heart that you are seeing here. Retrocardiac. Behind the heart, you are seeing air fluid level. This is suggestive of hiatus hernia. Okay, look at the X-ray as well. This is the air fluid level. And in the lateral X-ray, you can see this is the heart here. Behind that is this air fluid level, right? So always remember this description. When they tell you it is retrocardiac air fluid level, they are talking about hiatus hernia. Okay, they are talking about hiatus hernia, retrocardiac air fluid level. Okay, hiatus hernia. Going to next one, classical image, newborn with respiratory distress. These rounded lucencies that you are seeing in the lung, these are the bowel loops that have come into the lung. So this is congenital diaphragmatic hernia, most common being the Bogdelic hernia, left posterolateral, which is most common. Congenital diaphragmatic hernia has scaphoid abdomen, bag mask ventilation contraindicated. All of you know that, right? Abdomen radiology, spotter image, favorite for the exam, massive dilated esophagus. This is achalasia cardia. What happens in achalasia? The lower esophageal sphincter is contracted. That is why this gets dilated. So this gives the bird beak sign. Bird beak sign on barium. What investigation is this? Barium swallow for esophagus. Okay. So achalasia. What is the gold standard investigation for achalasia? It is manometry, not 24-hour pH monitoring. That is for GERD. Right? This is manometry. Bird beak, achalasia. Correct. Dysphagia more to liquids than solids. क्योंकि solids खाएंगे तो solids अपने weight और pressure से इसको open कर देंगे. Liquids, not a lot of pressure. So dysphagia more to liquids is what will be given here. Correct. Correct, Dr. D. Look at the image A and the image B. Tell me, what is the diagnosis in these two images? A and B. Very good. triple bubble sign and double bubble sign. These are 1, 2 and 3 bubbles that you are seeing here, and these are the 2 bubbles that you are seeing here. So triple bubble and double bubble. Single bubble is stomach, double bubble duodenum, triple bubble jejunum. So this is going to be jejunal atresia and this is going to be duodenal atresia. Double bubble is duodenal atresia, triple bubble is jejunal atresia, asked many times in the exam. This was asked in your last year NEET PG exam. On the ultrasound, this is where you are seeing the liver, and to the left of it is the stomach, and this is the elongated pylorus which looks like the cervix, right? So this is the wall, the muscle wall of the pylorus which is thickened, right? So this is the pylorus which is elongated with the thickening of the pyloric wall. This is CHPS or IHPS, hypertrophic pyloric stenosis. What is hypertrophied in the pyloric stenosis? What layer? The circular muscle is what is hypertrophied. Circular muscle is what is hypertrophied. Okay, so this is the pylorus here. What sign does it give? You look at the cross section. The stenosis and the hypertrophy, inner circle, outer circle, it gives the target sign or the donut sign, right? So that gives the target or the donut sign. Where else do you have a target or donut sign? Which other condition? Inner bowel, outer bowel. So bowel ke andar bowel, that is intersusception. Okay, that is intersusception, right? So target sign is also seen in intersusception. Very good. Classical image, what are you seeing here? This is the coffee bean sign. What is this coffee bean sign seen in? Sigmoid volvulus. Okay, this is sigmoid volvulus, coffee bean sign. Do you see hostrations here in sigmoid volvulus? No, the hostrations are absent in sigmoid. Okay, so there are no hostrations. Sigmoid volvulus, these 3 parallel lines which converge at a point, that is what is coffee bean sign. Freeman-Dahl sign bhi bolte hain, coffee bean sign bhi bolte hain. Freeman-Dahl coffee bean sign. What are you seeing here in this barium minima? Look at the barium minima. Barium has gone up and then it has formed this claw. Okay, what has the barium formed? The barium has formed a claw around the intersusceptum. So this is the claw sign of intersusception. What are you seeing on the CT? CT is giving this bowel within bowel appearance, the target sign. What history do they generally give in intersusception? The red currant jelly stool, right? There is going to be red currant jelly stool, that is seen, right? Okay. Going to next one, gallbladder pathologies. What is the first one showing? Has been asked in your exam. This is a gallbladder. You see a fold like this. This is a normal variant that you see a fold like this. जो fundus है वो ऐसे fold कर रहा है. This is a normal variant called as Phrygian cap. Okay, this is a normal variant, Phrygian cap, right? What is the next one here in the gallbladder? There's a small white area. You ask the patient to turn to left side. The small white area stays at its place. It does not move. So immobile, it is stuck to the gallbladder wall. That is going to be gallbladder polyp, right? There is no shadowing there. That's a polyp. This one which is showing the shadowing, you ask the patient to move and the stone also moves. This is posterior acoustic shadowing present. It is a gallstone. What is the investigation of choice for gallstone? USG. For renal stone, ureteric stone, CT. Why? Because gallstones are not calcified generally. Okay, so this is gallstone, posterior acoustic shadowing, right? Look at this one in the liver lesion. What do you think? It's a hemangioma, liver abscess, Kerolese or HCC? Yes. How do you identify? A lot of, so there's some confusion. Some of you say this is hemangioma. Some of you say this is HCC. How do you differentiate? How do you differentiate? Will you call it centripetal filament? No, right? Look at the lesion here, right? First of all, this triple phase CT, remember, is done for liver lesions, arterial portal delayed phase. You can see the lesion is more wide as compared to the surrounding liver on arterial phase itself. That means it is arterial enhancing. And as you follow this lesion on the delayed phase, rather than the more contrast coming in, you are seeing that iska contrast has gone and now it is appearing dark as compared to liver. So early washing of contrast, early washout of contrast, this is what you see with HCC. Okay, HCC mein rahega. So remember, HCC is supplied by hepatic artery, not by the portal vein. Hepatic artery mein the contrast comes first as compared to portal vein, and that is why it shows the early arterial enhancement and it shows early washout as well. It becomes dark on a delayed scan. Hemangioma will have first the peripheral nodular enhancement, and in the delayed scan you would see that it is like almost completely filled with contrast. The contrast does not go off, rather it comes into the lesion. Okay, clear with everyone? FNH, remember FNH का DD होता है fibrolamellar carcinoma, the variant of HCC. Both of them are differentials because they have the central stellate scar. So if in the liver lesion you have central stellate scar, then you think of FNH and FLCC. You can do MRI or a sulfur colloid scan to differentiate that. Okay? So early wash in, early wash out, it's going to be HCC. That is what you have to remember. What is this one here? What is this liver lesion? Kerol's disease, Ashwin, will have the central dot sign. Right? The central dot sign will be seen in Kerol's. Is this a liver cyst or this is a liver abscess? Abscess or cyst? See, look at the lesion is appearing gray color and it has a surrounding wall, which is a thick wall. It's not like a thin wall that you are seeing. So this is abscess. Okay, this is a liver abscess with a thick enhancing wall. Cyst has by definition a very, very thin wall. You do not generally see the cyst ka wall. Okay, it's so thin. You are seeing a thick enhancing wall. It's an abscess. Amoebic liver abscess versus pyogenic liver abscess. Generally, if it is solitary, it is amoebic liver abscess, and in amoebic liver abscess, you will have history of dysentery as well, right? Because first comes the dysentery, the entamoeba histolytica, then it invades the liver, right? So dysentery ke baad agar liver lesion hai, then you think of amoebic liver abscess. Okay, right? Now tell me what liver lesion is this? Liver में कोई lesion दिखाया है जो ऐसा white calcified lesion है. What is a lesion which calcifies in the liver? Calcifies like this in the liver. What is a calcified lesion in the liver? That is hydatid cyst. Okay, the last stage of hydatid, it calcifies like this. Okay, and look at this one. The gray tells you it is a fluid containing lesion and you can see the membrane floating. So what is this sign called as? This is the water lily sign of hydatid. Important. It is what Ghar B classification and what WHO classification? Ghar B is by. Remember, it is Ghar B, Ghar by 2. WHO 3 words, it is WHO 3 and Ghar by 2. अगर आप stage देखोगे तो Ghar B 2 and WHO 3. Okay? And what are you seeing in this one? There is a lesion which has multiple daughter cysts inside. So mother cyst ke andar daughter cyst, cyst ke andar cyst. Again, this is hydatid. There are multiple daughter cysts that come up within the mother cyst. Okay, is this clear with everyone? Right? Correct. This was asked in your last NEET PG exam. What do you see on this abdominal radiograph? If you look very carefully, can you appreciate this white thing there? What is that white there? What is this white here? This is the pancreas ka location. So this is pancreatic calcification. Whenever you have pancreatic calcification, remember C for C. Think of chronic pancreatitis. Okay, think of chronic pancreatitis, pancreatic calcification. Same thing you are seeing here in this pancreas. This is the pancreatic calcification, chronic pancreatitis. How is the pancreatic duct in chronic pancreatitis? It has dilated pancreatic duct, right, giving the chain of lakes appearance. Remember CCC for chronic pancreatitis, calcification, chain of leaks appearance. Okay. So calcification, chain of leaks, chronic pancreatitis. What are you seeing in this? Has been asked in FMGE exam, NEET PG exam quite a few times. A gray color lesion with a wall surrounding it. So a cyst-like appearance in the region of pancreas. There is background history of pancreatitis. This is going to be pseudocyst because it is uniformly, homogeneously gray color. There are no air foci that you are seeing there, which you see in a necrotic wala collection. This is a pseudocyst which forms after 4 weeks in non-necrotizing pancreatitis. That is when you call it pseudocyst, after 4 weeks in non-necrotizing pancreatitis. What are you seeing here? Look at the pancreas appearing bulky. There is this non-enhancing area. There is fluid accumulation there. So whenever they give you again your NEET PG PYQ, pancreas is bulky. What is it suggestive of? Acute pancreatitis. Fluid surrounding pancreas with bulky pancreas, acute pancreatitis. In acute inflammation, the organ becomes big and surrounding that is fluid, right? The edema comes in, the fluid comes in. Is this clear with everyone? Right? So bulky edematous pancreas with surrounding fluid is acute pancreatitis. Okay? I hope I'm audible and visible, everyone, working well on my side. Okay? Right, going to next one, look at this image. Okay, what is this here? CT with the renal lesions. What is it showing in the renal lesion? The dirty black appearance with the enhancing areas also. Dirty black areas with enhancing areas. What is dirty black on CT? It is fat. What is a fat containing lesion in the kidney? Angiomyolipoma, right? Dirty black with enhancing areas present. How will it appear on T1 weighted MRI? Right, it is going to be T1 white. Okay, remember fat is T1 white. And if you do a fat suppressed sequence, what is STIR MRI? STIR is a fat suppressed MRI. So you can see that on STIR, the regions which were white on T1 have become dark. That means the fat, it is telling you that it is fat. So it gets suppressed on fat suppressed MRI, right? The fat will get suppressed, the hemorrhage will not get suppressed, right? So remember, bilateral AML is seen with what condition? Tuberous sclerosis. Okay, tuberous sclerosis. What is this one here? Is this a renal cell carcinoma? What is this image showing? Is this a renal cell carcinoma? Very good. Gray color, fluid, without any, wall that you are seeing there. There is no enhancement that you are seeing there. So non-enhancing, no significant wall. This is going to be renal cyst. What Bosniak classification? A simple renal cyst is a Bosniak category 1. Right? It's a simple cyst without any calcification, no septa, no enhancement. Okay? Yes. And when you see in the kidney a lesion which has this enhancing areas, necrotic areas, solid enhancing areas, think of renal cell carcinoma. The patient will have history of flank pain, hematuria, old patient, right? It's going to be RCC, which has the solid enhancing areas. So angiomyolipoma will have dirty black area. Cyst will have, right, non-enhancing. Okay. Coming to the various calcifications in the kidney, what is the first one? Which has this shape like the stag horn. So this is going to be stag horn calculus. Seen commonly with Proteus or Klebsiella infection, urease positive. When you have bilateral renal calcification appearing like this triangle areas with the lucent areas in between. Bilateral is some metabolic condition, right? Some systemic condition. This is medullary nephrocalcinosis. What endocrine condition? Your last year INI-CT exam question. Where do you have hypercalcemia? Which endocrine condition? Hyperparathyroidism, right? So when they give you the renal calcification bilateral, think of hyperparathyroidism. Second one is not the putty kidney. Third one is the putty kidney, right? Remember putty, T for TB. TB, putty kidney generally that you see is unilateral. The kidney is shrunken and the pattern of calcification that you see, it's more like this lobulated appearance that you are seeing in the renal calcification, right? It has this more lobulated appearance and generally it is unilateral shrunken kidney. Third one is putty, right? In renal TB, generally they give you history of sterile pyuria. Okay, that's an important history there. Sterile pyuria, right? Clear with everyone? हाँ, ये भी एक्सरे है, ये भी एक्सरे है, ये भी एक्सरे है. Calcification will appear white on a plain X-ray itself without any contrast, right? So ये सब images X-ray हैं. Going to next one, suppose this image comes in the exam. Look at the image carefully. Always try to read if there is anything written on the image. What is written on the image? There are important clues given in the image. It's a IVP after 20 minutes. So that's a major clue to tell you that what condition are they talking about. Very good, right? So IVP, when we take a delayed image, right, after 20 minutes, it's basically we are trying to see that delayed image mein, is there any excretion happening? Look at the right side kidney and the ureter are well seen. The left side kidney is hydronephrotic and you are not seeing the ureter even after 20 minutes, right? The contrast is not able to go into the ureter. So there is an obstruction here at the level of the pelvis and the ureter. So this is left-sided PUJ obstruction, right? Left-sided PUJ obstruction. What are you seeing? Hydronephrosis. Are you seeing the ureter there? Ureter? No. What will be the investigation of choice? IVP with delayed image, right? IVP with delayed image to rule out that there is actually, right, no slow excretion. It's a absent excretion. Why left? Because this is left side, right? This is right side, this is left side. Right? Is this clear with everyone? So this is PUJ obstruction. Look at this CT also. This is the kidney. This is the pelvis of the kidney. You can see that it is dilated, right? So dilated pelvis, PUJ obstruction will look like this on the CT. This is a dilated pelvis. You see the images ahead, you will see that the ureter is not dilated. Okay, the ureter is very small. Okay. And what is this one here? Is this a IVP? No. This is the bladder and this is the urethra seen. Bladder, urethra seen. This is MCU. In IVP, you do not see the urethra, right? It is KUB, kidney, ureter, bladder. Urethra नहीं दिखता है. तो ये MCU में सिर्फ micturating cystourethrogram में इतना ही दिखना चाहिए. But you are seeing the ureter and the kidneys telling you that what is happening here. There is a reflux which is present, right? So this is VUR. What is the investigation of choice for VUR? MCU. When the bladder contracts, the contrast will go up, right? And what is the history given? History of recurrent UTI in a child. Okay, that's the history that will be given for VUR. Is this clear with everyone? Right, so MCU is also called as VCUG, widening cystourethrogram or micturating cystourethrogram. For that, you will do MCU. Going to next one, the CT image is easy. The two kidneys are fused together like a U-shaped. So this is the horseshoe kidney associated with Turner's, right? It is associated with Turner's. Now, what are you seeing in the IVP here? Look at the kidney, how it is trying to go towards the vertebra and towards the vertebra. So both the kidneys are trying to join hands with each other, right? So this is like this flower vase appearance or joining hands appearance. Handshake, joining hands or flower vase appearance. That is what you see in horseshoe kidney. Okay, that is what you see in horseshoe kidney. Clear with everyone? Yes, E. coli is the most common organism for UTI. This is not the maiden waist. Maiden waist, you will say that when you will see the ureter, which is overlying the vertebra. Okay? Normal ureter goes paravertebral, paravertebral. In maiden waist, you will see the ureter coming over the vertebra, telling you there is medial deviation of the ureters. Maiden waist is seen in retroperitoneal fibrosis. Okay. Here the ureters are still paravertebral only. Okay, they are paravertebral in location. They are not overlying the vertebra. Okay. Coming to important neuroradiology images, what is the diagnosis here? Right, your recent INICT exam had image like this. Pancake kidney is when the two kidneys are fused together, upper lower pole, and they are low lying in the pelvis. Okay, horseshoe में सिर्फ एक pole fuse होता है, pancake में पूरा fuse होता है. Right, this is NCC because you can see a neurocyst with a scolex inside. Cyst with dot appearance. Right, you are seeing the cyst with dot appearance. It is NCC. Okay, it is NCC. In the late stages, it will get calcified and it will give the starry sky appearance. Okay, then it will give starry sky appearance. What is this one here? Same, NCC, tinea solium starry sky. Calcified जब होगा तब बोलेंगे. What is the diagnosis here in this case? All the images are pointing to diagnosis. Very good. This is TB. How do we know? Very important. Look at this MR spectroscopy. You are seeing a peak which is coming towards the right side of the spectrum. What peak comes at this location is the lipid peak. Lipid peak, mycobacteria, mycolipid give the lipid peak. You can get hydrocephalus with TB. This is the meningitis which is shown here, right? So that is the thick enhancing meninges that are seen, a lot of basal exudates, and these are the conglomerate lesions, right? So conglomerate lesions which are there, along with that the hydrocephalus, meningitis, all of these is suggestive of TB. Lipid peak is important in TB. Next one, what is this condition here? What congenital infection is this? Is it? No, it's working fine. Soap bubble is cryptococcosis. Cryptococcus. Very good. You can see this white calcification surrounding the ventricle. Very important. Periventricular calcification. Periventricular calcification is CMV. Remember, virus has ventricular calcification. CMV is what gives this periventricular calcification. And what encephalitis is this one in the second image? What encephalitis? What is a lobe of the brain here? Temporal lobe, basifrontal lobe is affected. Whenever it is temporal lobe, you think of HSV encephalitis. Again, very important. Whenever the temporal lobe is involved, think of HSV. What HSV is it? HSV1. Okay, HSV encephalitis. Very important. Next one here is this caput or is this cephalhematoma? Is this caput or is this cephalhematoma? No. This is not crossing the midline, right? This is the midline that you are seeing here. It is on one side itself. It has this white periphery telling you ये periosteum elevated है. उसके अंदर calcification भी आ रहा है. So this double skull-like appearance with the calcification inside, right? So the double skull appearance with calcification inside tells you this is cephalhematoma, right? It is something which stays for long. It does not cross the midline, right? It is subperiosteal. It is not crossing the midline, right? So this is cephalhematoma, has been asked in your NEET PG exam previously. What investigation is this and what is the diagnosis? First, tell me the investigation. Very good. This is DSA. The black vessel tells you that this is a DSA. Remember, digital subtraction angiography is done in fluoroscopy. Like you saw, ERCP can be black or white. DSA also can be black or white. This vessel that you see here, the tortuous vessel, is the internal carotid artery. So, carotid angiogram Okay. Carotid angiogram you have done. What are you seeing in carotid angiogram? You can see this vein also, which is the ophthalmic vein, cavernous sinus ophthalmic vein, which have picked up the contrast. So telling you that there is a direct communication between the carotid and the cavernous. So this is carotico-cavernous fistula, right? What will you see here is a early draining vein. The vein will show early opacification. This is carotico-cavernous fistula, right? In fistula, there's a direct communication between artery and vein. So rather than going to artery, arterial, capillaries, vein, the vein is showing early enhancement, early contrast pickup. Carotico-cavernous fistula will have pulsatile proptosis, right? Pulsatile proptosis is what will be given in the question. There can be history of trauma ke baad, because trauma can lead to this carotico-cavernous fistula. Is this clear with everyone? Yes. Why not aneurysm? Aneurysm mein you will see the vessel which has this, the dilatation which is going to be there. It is not the carotid artery anywhere showing any dilatation. Difference between glomus and carotid body tumor. See, both of them, be it glomus or be it carotid body tumor, they are paragangliomas, highly vascular tumors. Both of them will show a lot of contrast enhancement, salt pepper appearance on MRI. The difference is basically based on the location. And you have glomus tympanicum, glomus jugulare, and carotid body tumor is at the carotid bifurcation, right? But if you look at the origin, like they are paragangliomas. Okay, what is this one here? What do you think is this image showing? Anyone, what is this image showing here? See the comments just a minute. Okay, now I can. Yes, this is the vein of Gallen malformation. In these cases, when you are given the history, it is enough to make a diagnosis. A neonate, a newborn with hydrocephalus and with heart failure. Okay, when they give you this history, a neonate with hydrocephalus and heart failure, then it is enough to make this diagnosis of vein of Gallen malformation, which is again an AV fistula, right? You would see this vein of Gallen cup precursor actually, which is there draining into the straight sinus, classically below this corpus callosum, the dilated vessel draining into the straight sinus in the sagittal image. So this is again an AV fistula. Because of the AV fistula, there is this high output cardiac failure and there is hydrocephalus. Okay, that's going to be classical there. Okay, coming to musculoskeletal, tell me what condition is this? Very good. Classically, where you are seeing this subperiosteal resorption, the surface of the bone, because of the resorption, from being flat, it has become concave. This is hyperparathyroidism, which shows subperiosteal resorption, right? It causes bone resorption, which is classical of the hyperparathyroidism. It first starts in these phalanges, so the hand X-ray will show the features first. Okay, subperiosteal resorption, hyperparathyroidism. What is this one here? Is it multiple myeloma? Is it vertebral metastasis? Is it TB? Is it ankylosing spondylitis? What is it? Is it a chance fracture? No. See, what is happening here is this which you are seeing here is not one vertebra. Every vertebra posterior element, every vertebra's posterior element, this is one vertebra, this is second vertebra here, right? So you have more than one vertebra which is involved, telling you the intervertebral disc is completely gone. You can see this collection which is formed here, right? So remember, this is two vertebra involved with intervertebral disc involved. Whenever the intervertebral disc is involved, you think of what? Spine, right? So this is TB spine, which involves the intervertebral disc. This is not just one vertebra, okay? There are two vertebra involved. When you see this sequestrum, involucrum, cloaca, what are you thinking of? Chronic osteomyelitis. The patient comes with history of discharging sinus, right? What is the sequestrum? Sequestrum is the dead bone which is sequestered inside. How does it appear? It appears more white, more dense. So this white dead bone in the center, that is sequestrum. Involucrum is the involuting bone, the periosteal reaction, the healing which is happening is the involucrum, right? So the periosteal reaction, that is going to be involucrum, and the opening, cloaca, is the opening, right, through which that dead bone is coming out, right? So cloaca is the opening, sequestrum is the dead bone, and involucrum is the new healing bone. Okay, dead bone is more white. Okay. Yes, what are you seeing here? Look at this white line in the center. That's the dagger sign, the fusion of the supraspinous interspinous ligament. Dagger sign. Ankylosing spondylitis. Spondylitis matlab spine ka inflammation. Ankylosing matlab fusing. Where does it start? It starts in the SI joint. So you would see first the SI joints which are fused. Then the entire spine gets fused, giving the bamboo spine appearance. Right, bamboo spine, dagger sign, SI joint fusion, all this is seen in ankylosing spondylitis. Okay, HLA B27. Coming to OBGY, what is this one here? Classical. You are seeing the eyes, right? The brain parenchyma, you are not seeing like a frog. Eyes ke upar kuch nahi dikhta hai. So the frog eye appearance, right? That is anencephaly. Look at the sagittal image. This is the baby lying here, the face, and this is the body of the baby. You are not seeing the white calvarium, right? The calvarium, the skull is absent, right? The calvarium, the skull is absent, brain is open, CSF goes out, polyhydramnios. This is anencephaly. Earliest anomaly to be identified on ultrasound at 10 to 11 weeks. Management has to be MTP. Folic acid will not help now, right? It is anencephaly. Correct. Next one, banana sign, INICT exam question. Banana sign is seen in spina bifida, right? A neural tube defect, spina bifida, gives you the two fruit signs. One is banana sign and other is lemon sign. What happens with the spina bifida, meningomyelocele? There's a traction on the brain structures, right? So this frontal bone becomes concave like a lemon sign, and the cerebellum becomes curved like a banana. Okay, the cerebellum becomes curved like a banana. So banana sign, and the other sign that you have is the frontal bone becoming concave. That is the lemon sign. Okay, so neural tube defect, spina bifida gives this lemon sign and banana sign. Is this clear with everyone? Rail track and trolley track sign. So in ankylosing spondylitis, what is happening is your interspine is getting fused. Your vertebra are also getting fused by the formation of the syndesmophytes, right? So all these parallel lines which are coming in, that is what gives that railroad or the trolley track appearance. Okay, clear with everyone? Yes. Going to next one. What are you seeing here? Is this normal or abnormal? This is the double bleb sign, which is normal appearance in the early pregnancy. The outermost that you are seeing here is the gestational sac. The two inner structures, this is the yolk sac, this is the amnion with a small fetal pole inside, right? So what gives this double bleb sign on ultrasound? The double bleb sign is the yolk sac and the amnion, which is inside the gestational sac. Okay, that forms the double bleb appearance. Okay, so that is the double bleb normal. What are you seeing here? What is this investigation here? And what are you seeing here in this image? No, this is not double decidual. This is double bleb. Is this ring of fire? Remember, every orange colored image that you see is not a ring of fire. Ring of fire means actually will look like this ring. Okay, it will have the orange vessels in a ring. This is, again, this is a Doppler, a power Doppler. The white inside is the endometrium and you are seeing the vessel supplying it. This is a vessel. This is a feeding vessel supplying the endometrial polyp. Feeding vessel sign is seen in endometrial polyp. Okay, remember endometrial polyp, which can come with bleeding, intermenstrual bleeding, metrorrhagia. Endometrial polyp is feeding vessel sign. Okay, this is feeding vessel. Ring of fire is seen in a ectopic or a ruptured corpus luteal cyst. This is endometrial polyp. Okay, what are you seeing here in this image? What are you seeing in this image? Very good. Aortic dissection. Can you appreciate superior vena cava, ascending aorta, pulmonary artery there? Look at the ascending aorta, which is dilated, plus showing this bifurcation. There is bifurcation in the descending aorta also. So this is aortic dissection involving the ascending aorta plus the descending aorta. So this is going to be what Stanford classification? Stanford A. Whenever the ascending aorta is involved, it is Stanford A. It requires surgery. Okay. So this is going to be aortic dissection, right? Stanford classification. And what are you seeing in this image? Look at this of the same patient. This is the abdominal aorta, which is dilated. This is the lumen with the contrast, and surrounding that is the thrombus or the hemorrhage. You can see this white hyperdense hemorrhage as well. So this is the dilated aorta. Okay, the dilated aorta that you are seeing here. This is abdominal aortic aneurysm. When do you call it abdominal aortic aneurysm? When it is dilated more than 3 centimeters, then you call it abdominal aortic aneurysm. What investigation do you do before doing the intervention for abdominal aortic aneurysm? The best is the CT angio, not the DSA, because DSA will not show you this area. CT scan shows you this thrombus or the hyperdense bleed wala area. DSA will show only the patent area, right? So CT angio, what needs to be done before the intervention? Okay, CT angio needs to be done. What are you seeing in this image here? What are you seeing in this image? नहीं, unstable patients में transthoracic नहीं, transesophageal. In aortic dissection, particularly thoracic aorta involvement, if the patient is stable, you go for CT angio. If unstable, then transesophageal echo. TEE, not TTE. TTE is transthoracic. Very good. Look at this. This is the pulmonary artery. You can see this filling defect in the pulmonary artery, filling defect in the pulmonary artery. The contrast is not getting filled there because there is pulmonary embolism, right? There is pulmonary embolism. What is the investigation of choice? CT pulmonary angio. Any vascular pathology, you will have to do a contrast scan, right? In MRI, you can make the vessels look white without contrast, but in CT, you will have to give contrast to make those vessels look white. So CT pulmonary angio is going to be investigation of choice for pulmonary embolism, right? There's a filling defect there. So yes, that was about the most important image discussions. We've had like almost more than 2 hours ka session, and I hope this gives you a quick insight into how to interpret the images, not to make mistakes in the most commonly asked images. I've told you all the tips and the tricks, right? So thank you so much. Apart from that, of course, radiology is endless. It is limitless, right? So the details have been covered in the videos on the PrepLadder app. This is just like your final brush up, right? I hope all of you have enjoyed this. Thank you so much for all the love. And that's great. The coach surgeon. That's why. Make mistakes here so that you do not make mistakes in the final exam. Okay. Oh yes, Monimola, wish you a very happy birthday. Stay blessed, happy and healthy always. Did not want to break that, the tone in the middle, and that's why, you know, I just thought that I'll do it in the end. Thank you. Okay? Shreya, anatomy, a lot of it has been covered in the videos on the app. Okay? All right. Thank you so much, everyone, guys. See you again soon. Till then, goodbye. Take care and keep studying, keep revising, and keep winning. Thank you so much.